Good morning, ladies and gentlemen. Speaking before a crowd like you can be very intimidating for me who comes from a remote country town. However, John reassured me that Australians are friendly people. The theme The theme for this conference, to integrate, innovate, and inspire, with a particular focus on the pre-vocational and postgraduate medical education, is indeed a unique theme, and I like the way it was phrased. Why? Because it brings to mind actions that are required to probably move us from our current status to where we should be going into the future, to produce transformed professionals for the 21st century. That, to me, in a capsulized form, is actually education today for tomorrow. While preparing for this talk, it crossed my mind to actually ask, what can I contribute to what you have already known this far? I come from a small country, though populous, and let alone from a remote town down south of the Philippines. So I posted this question to John. What can I share? Well, he reassured me through his email and just simply said, well, you just simply share how you transform innovations into practice. In short, perhaps, how you make your ideas real. But in a more succinct way, he said, how you integrated your innovative and inspiring medical education ideas into health gains. So the three verb actions, integrate, innovate, and inspire, he said, I want you to focus on the word inspire. That to me is a tall order. And I think the best way that I could probably inspire is to simply share to you our stories. One of the things that intrigued me is that you put the word integrate first, innovate, and then inspire in that sequential order. And I was just wondering, perhaps that might be your diplomatic way of introducing innovations into the mainstream. We were more radical, however, we reversed the order. We started with innovations, and we integrated these innovations. We call them innovations, but actually they are reforms. And then finally, we inspire people to join the ranks. You see, innovations actually starts from simple and small beginnings. In fact, to achieve a bigger impact is through the increments of small successes. Innovations are actually mind-setting. But to us, it was really a need. There was a need for us. It was a must. Because we were all graduates from the conventional medical education programs. And for us to make any changes, we need to survive ourselves. So we need to get out of the mainstream and even question the status quo. But we question not the whys, but we question why not. The best way to predict the future, according to Abraham Lincoln, is actually to create it. However, Kay said the better way is to reinvent it. But we thought the even better way is to innovate and simply redesign what is already existing. So today, let me share to you our creation. How we use the transformative power of innovation to bring reforms to our medical education system and, more importantly, to our health system. Actually, the work in our country, in the Philippines, was born out of our desperation and disappointment of the failed promises of the traditional and conventional curriculum. So quietly, timorously, and often in isolation, we decided to introduce something different. Not for the sake of wanting to be different from the rest, as we were the young kid in the block, but we wanted to be different for a purpose. For fear that we might be labeled as radicals, we decided to label our intentions as innovations, and at best, simply as alternative options. This was not threatening to them. I have a friend, Dr. John F. Smith, who comes to visit me, and he's from New Zealand. He's a community psychologist, and he would stay with us for a month. And he said, "Chris, what you're doing here is what most of us know simply in theory." That was 20 years ago, where terms like longitudinal learning, active training, service learning, social accountability, experiential teaching and learning, student-centered learning, integrated curriculum, community-engaged medical education, distributed learning, contextual learning, were terms that were not yet familiar or even unheard of. But we were experimenting on this, but little did we know that they will become major issues in medical education. Our concern was to produce graduates who will help solve the health problems in the region. We wanted to introduce to them the philosophy that health for more is much better than the health for all ambitious intentions. Dr. White Kerr in 1961 published an article in the Ecology of Medical Care in New England Journal in 1961 when he said that out of 100 patients, only 750 will become symptomatic. And of this, only 250 will seek consult from a medical practitioner. And out of these, only 9 will eventually be hospitalized, and more so in a community hospital. And of these, finally, only 1 will be hospitalized in a university hospital. In a similar study by Hackettry, these were among pediatric patients, he said that 8% are seen by medical practitioners, by doctors, by pediatricians. Of these, only 2% will eventually be hospitalized. 60% to 80% of them, however, are attended by the mother. So these authors were thinking that if training is limited to training and teaching hospitals, then there is a mismatch occurring by what we are teaching, the competencies that we are honing on our doctors, with the future roles that they will have to play. You see, health is a social enterprise. In fact, it is a social construct. So therefore it follows that medical education and medical practice as well is a part of that social system. In fact, health status is socially determined. It is an outcome which is determined socially. In the Philippines, health inequity is very real and very apparent. You can see this across social classes. So that it has become, in fact, an acceptable norm. Only the few privileged people have access to real good medicine. If you look into the countryside also, the same scenario actually happens. It has been said that in a system theory, everything else affects everything else. And so is health. Health is affected by the environmental, social, political, and economic factors. They do not only affect health directly, but they also affect the beliefs and the attitudes of our people, and so therefore also affect their behavior. There are two concepts of healthcare: the biomedical model and the social model. There has been a constant struggle between these two, trying to maintain balance between the two. Unfortunately, the biomedical model is actually gaining grounds since the 18th century and has been dominant since then. Instead of arguing between the two, which is better or worse than the other, I would rather say that we use these as analytical tools to help us identify, interpret, and even deal with some of these or all of these health issues. The social model believes that the cause of illness is found outside the human body. It is in the way the society is governed and the way it is organized and patterned. The biomedical model, on the other hand, believes that the cause of the illness is found in the human body itself. That despite its enigmatic, very profound construction, it can be reduced to understand disease in terms of its human parts. So that the cause of illness is simply just nothing but the malfunctioning of these parts. Unfortunately, again, this biomedical model has become the dominant trend in our century. Health, however, also has many dimensions. It has the physical, the mental, the emotional, the spiritual, and the social dimensions. These all constitutes the individual dimensions, and the approach to this is through the individual healthcare. Beyond this is a societal dimension. Here we talk about the shelter, we talk about peace and order, we talk about food, we talk about the income, we talk about the politics, we talk about economics, and beyond this, we talk about the environment as well. Here we talk about water, we talk about the climate, we talk about the forests, and we talk about resources. All of these constitutes the wider dimension of health, and we approach to study this through the population health care. But beyond this, there's still another wider dimension, which is the global dimension. Here we talk about global trade, global economics, the pandemics, the migration, the border issues, the climate changes, the population explosion, the social inequities and inequalities. This is what we call the expanded dimension. Again, the approach is through population healthcare. In the Philippines, however, our training is basically a biomedical model. It has been actually an adapted model from the Western culture, part of the colonial imprint made on us. Unfortunately, this has failed to serve us well. So here we have a picture. We are led to some painful situations wherein prominent universities would brag about their ability to do some special or unique brain surgery. And yet, just 5 kilometers away from their doorsteps are actually people suffering from cholera, dying by the hundreds. So the question I would like to pose here now is, how do you bring all of these issues to bear into an educational training that is becoming more demanding than ever and more expanded in the future? I come from one of the most underserved areas in the Philippines. By the statistics, in 2003, out of 40 poorest municipalities in the country, 28 of them are found in our islands. 14 is found in the Zamboanga Peninsula, and the Philippines' poorest municipality is actually in my peninsula. In 2006, of the 10 poorest provinces in the Philippines, 7 is found in my region. And in 2007, the hunger incidents, 2 of them ranked 2nd and 3rd in my region. We have a population of 3.8 million with only 2 medical schools in the area. The infant mortality rate is 75 per thousand. It's 70% still rural, and 80% of the municipalities are without doctors. It was against this background that we came together to organize the Zamboanga Medical School Foundation in 1994, which eventually was absorbed into the University of the Ateneo de Zamboanga School of Medicine. Our decision was to break from the traditional model. We decided to integrate the 2 models, and we embedded the biological basis into the social, cultural, political, and environmental issues of the region. In a nutshell, we introduced a triple helix curriculum of problem-based learning, and community-engaged medical education, and a competency-based learning and assessments. We decided to become radically proactive. We decided to collaborate with the community, and with them, we decided to make a new curriculum. And we decided that it's going to be a health development project. And the agents of change are actually the students themselves, the faculty, the community, and some of the graduates. We decided to debunk the traditional curriculum. And we decided to expose our students to the realities. We used democratic selections for admission, wherein the community people are involved in the selection of our students incoming. We decided to collaborate with stakeholders, particularly the community, and we used the local health priorities together with the national health priorities as eventually coming in as our core curriculum. It's not easy to become innovative against 42 medical schools in the country. However, to be innovative is the way to go to be relevant. We need to question the status quo, and sometimes we need to force a paradigm shift. Health development in my country has long been overdue. Health, as defined by the WHO, is a state of well-being and not just simply merely the absence of infirmities. Good health, therefore, is not the default condition of health. We take the reverse as true. Disease and illnesses are actually the fallback from good health. Therefore, the emphasis should be in teaching our students the factors for good health over the causes of illnesses. We embedded the biomedical health care against some social factors, cultural, political, and community issues. We decided that it would be a combination of both the individual health care and the population health care. These two must always complement each other. Health is socially produced, as I've said earlier. However, although the immediate medical problem as the entry point for health care is very much biomedical, the health integrity of the individual and the community actually largely depend on the broader social conditions that has to be addressed. In a more succinct way, we introduce what we call the sandwich model curriculum. The first and second and third year, there is the problem-based working strand. Here, they also do some hospital bedside rotations, and this usually occurs weekly. But just juxtaposed with this is the population strand, in which the student spends 1 month every semester, or equivalent to twice a year, in the community, staying with the people, living with the people, and working with the people. And here, we embed courses that will eventually lead to masters in public health. The first semester, or 6 months of the first year, is devoted mainly to defining and helping them appreciate the future roles that they will take on. The last 6 months of the third year is actually their hospital clerkship, where they will spend 6 months in the hospital, rotating in the various departments of the hospital. And these where they hone their professional skills. On the fourth year is where they spend a continuous 10 months in the community, living again and staying with the people in the same community that they started right on their first year. There again, we insert some of the other courses on public health. These eventually will complete their MD requirements. But beyond that, we have in our country the required postgraduate level year, which is the 5th year, which is the postgraduate internship. Again, they spent 6 months in the hospital, and then the next 6 months, and as a community rotation, doing research, intervention research for that matter. By then, they would have completed all the requirements for the MPH, also completed the requirements for them to be able to take their National Licensure Board exams. This, in a nutshell, is what we call our MD-MPH program, which is iterative. They rotate to the hospital, then to the community, and back to the hospital, and back to the community. This is a picture of our students in a problem-based learning session, and immediately after the problem-based learning, they're exposed to the hospital to real patients. where they are able to put a face in the cases that they have seen in their problem-based learning. They also learn how to do professional skills, and they go back to their session, bringing with them a fresh experience of having seen a real patient. We also focus on developing in them the skills on history taking, physical examinations, and doing some supervised procedures. We expose them to the community, they live there, and we use the community, we use the students to help in the transformation of the community, but we also use the community in helping the formation of the students. We have to this date produced 305 medical graduates. Of these, 298 have been ready to take the medical licensure board exams. And of these, 292 have passed the medical board licensure exams, giving us a performance rate of 98%. We have, in 2008, a 5th placer in the national board exams. In 2010, we have a 9th placer. And in 2014, we have the 8th placer. And very recently, in the 2015 licensure board exams, we had a 6th placer, and all of our graduates passed the board exams, giving us a 100% passing rate. Thus, we were considered as the second top performing medical school, small medical schools, because our entry point every year is only 50 students per year. This is the map of the area of the peninsula where I work. And these are where our graduates are. %93 are still in the country, serving in the areas. 81% is found in the region. 60% are with the government services. 40% are working in remote, doctorless areas. And only 6.5% went abroad. And even this, they have served at least for 4 to 6 years before they left. Most of them had to go because they married a foreigner in the first place. This is the infant mortality rate of our region. In 1995, you can see the range was between 83 per 1,000 live births to 55. By 2003, it has dropped down to 9.2. By 2008, it has even further dropped down in other areas. And by 2014, it has eventually dropped down. I think I'm not claiming that the cause of the drop in the infant mortality rate is because of the existence of our medical school in the area. Our research still have to be done to find out the linearity effect. But later on, I will show you a film which shows to you the work of our students in the community, all of which together can be said to contribute to the decrease in the infant mortality rate. This is the famous People's Needs-Based Health System by the WHO, designed by and introduced by Dr. Bolin. And you have here the various stakeholders involved, the health professionals, the academia, the communities, the health managers, and even the policy makers. I think we have been able to connect the health professionals with the academia and with the community. But we're still struggling to connect the health managers and the policy makers with the whole system. One of the things that we have asked ourselves, and these were the questions of our students, thus the training of local leaders on governance and leadership and management would lead to improved health in the region. You see, our political system has devolved from a national centralized governance to a local government control. Unfortunately, the local leaders are voted into power by popular vote. And so therefore, those who get into positions are people who may not have the skills for governance and leadership. So we decided to introduce a program called the Bridging Leadership for Health. Here is a picture of local governors and leaders who come to us for training, and we provide training with them in their locality as well. And the idea here was, if we could bring in leadership skills to them, then probably they will begin to see health as a central focus rather than a peripheral issue concerned. In the past, we always thought that to be good and to be competitive is we need to be globally accepted. We wanted to be globally equal and competitive as well. And we felt that that is a way of assessing that we are doing well as well. But we soon realized that these global standards are actually inappropriate for us. So instead we decided that we should be ourselves, independent, self-critical, and above all, self-respecting. So the question is, how can our small medical school contribute to resolving global health inequities? We can do that by, first of all, acting locally, by taking care of ourselves, by breaking away from these global standards, by being independent and self-reliant, and to develop a local model curriculum that is most suitable for our own needs and our own culture, to address our own health problems. In conclusion, I'd like to share with you these capstones. As developing countries struggle to find solutions to health workplace and health outcomes disparities, we, the volunteers in Zamboanga, have shown a way forward to assert that historical disadvantage does not have to be our ongoing destiny. With this, I'd like to show to you a short clipping of the working of our students in our community. Can we have it on, please? We're talking about 3.8 million people inhabiting this peninsula called the Zamboanga Peninsula. There are 18 municipalities without doctors, and the infant mortality rate is 75 to 80 per thousand live births. And we noted also that people who are able to study medicine, usually the upper middle class, would go to Manila, which is north of the Philippines, and study medicine there. And usually after finishing, they don't come back. So always the region would be deficient of doctors. When we started, we didn't have enough financial backup. It was an initiative in which everybody comes in a collaborative approach, contributing the share that they can contribute. The idea there was for the doctors to contribute their time as part of their contribution, and the Ateneo de Zamboanga would provide the kind of infrastructure, the buildings, the classrooms, the other office functions that is important to run a medical school. And of course, the businessmen were challenged to raise some initial seed money that will provide as a beginning budget for the medical school. We started with only $500 as a seed money. So when we started the medical school, we thought that it is important for us to combine both the biological model and the social model. Hence, we decided that it has to be a community-oriented, community-based medical education, in which the community becomes the laboratory training for the students to learn about the social issues, the cultural issues that come into play, including the political issues that affects the development and promotion of health in an individual.
We introduced different lectures. We didn't necessarily create new groups, but rather we just tapped on existing groups like your mother's class. Each barangay has that. So what we did is we supplement, and we didn't really go against the current system that's in place. What we did was utilize the systems in place and push it to a more, push the frontier.
I would be bold in assuming that one of the things that caused our pneumonia rate from being top 1 in the causes of morbidity in the community to top 4, now top 4 in the causes of morbidity of the community is our intervention, the Child Intensive Care, our pneumonia advocacies, our lectures, and our home management program for our mothers.
Nalipay kayo ko nga naabot ang yellow boat nga na-provide sa mga bata dito diin maka-eskwela na jud sila panahon nga mabuntag makasakay na sila aduna na sakyanan tingala man mi nga ano kanunay nga absent maliit sila nagkaroon mag-drop out na sila so dapat kami mag-drop out before pa jud so pag-abot na diri sa yellow boat na-notice na ako nga gamay na lang ang mag-drop out kanan while waiting nga mga mag-labor mga anak sila kay wala may kayo mga balay dili nga masaan na himo to happy house gama sa mga butilya in the first place ngano nga na-come up na mo ang dingding nga butilya ang mga gamit nag-volunteering yun ang mga nanay paghatag o mga butilya diin mo kagisuda na mo simento balas dayon ang labor adto pod voluntaryo po nila nga ikuan gyud kinasing-kasing. Malipay ko nga murag gali nga makahilang ko ba nga so far wala gyud naabot niya dili gyud makainggil ko ani si Michael kapag si Michael mo gyud nagkuan nga makahimo aning botilya nga nagwonder pagali ko mahimo kang building ang botilya unsa ka pagbarog sa botilya pero nakita gyud namo karong pod sir nga naagibihan ibarog gyud ang halfway house.
And I think we're beginning to see just a span of 2 decades now in our existence that we're already beginning to see solutions to our health problems. With each one of the students handles and do a research that will solve one particular health problem of the region. So you can imagine now, if you have a class of 45 fielded out into the community, you have 45 health issues that are being addressed, and a search for answers and solutions are done using local resources and local capabilities to solve the health problem.
Thank you very much sa programa nga gihatag niyo sa mga sa likod kay dako yung epekto sa kausaban sa among kaigsunan subanin. I'm very proud to tell you, dili gyud ako kanang pinotbot. From my heart, din ako nga nakita dyan ako ang usapan sa tao.
In the end, we hope that by being here in the community, we inspire them to think for themselves, to rely on themselves, and not just rely on the barangay council, on the government, but rather to believe that they can do whatever they want by themselves, to be able to prosper by themselves.
Sa akong kagalingan, pasalamat ko nga niya sila na sign sa mga sulod sa upat katuig nga bisan pa sa ang mga tao nga hinay ang suporta sa umpisa tapos nagkahinay-hinay nga unta dili sila bitaw mga tao nga
ang suporta nagkahinay.
We want transformation of communities. When we live in the community, we hope that it is not only the community that is changed, but also us. Eventually, the community becomes part of us. Wherever we go, we have that understanding that we are involved.
Thank you very much.